Lewy body dementia is the second most common form of dementia after Alzheimer's. It affects millions of families worldwide, and most people have never heard of it.
Regrettably, Lewy body dementia is often misdiagnosed or not recognized by the medical community.
Dr. James Galvin of the Comprehensive Brain Institute is one of the world's most renowned Lewy body dementia experts. He's been diagnosing and treating patients for over 25 years.
Lewy body dementia is the second most common cause of memory problems after Alzheimer's disease and has specific criteria that help us make this diagnosis. It's a progressive change in memory and thinking functions, signs of Parkinson's or slowed movements, visual hallucinations, fluctuations, that's alterations in attention and concentration, and REM sleep disorder. This is people acting out their dreams. A patient may appear sleepy or drowsy during the day despite the fact they slept the night before. The patient may have train of illogical or incoherent thoughts. So you may ask them a question and they give you an answer, but the answer is not to the question that you asked. These are very, very common symptoms found in 70 to 80% of all cases, but very, very difficult to diagnose.
Norma Lowe made it her life's mission to help others after her mother died from Lewy body dementia. Norma launched the Lewy Body Dementia Resource Center in New York to provide both patients and caregivers with Lewy body information on a local level, and she did it with a personalized approach. Norma is now expanding these nonprofit services to Florida and many other states.
When families and patients are looking for assistance, when they're looking for ways they can find information, one of the great ways to go about do this is to look at the Lewy Body Resource Center. So this is a group that set up a website and large amounts of information to provide additional services for families and for patients.
We wanted to incorporate and help as many people as possible because we know how much care, support, and specifically love is needed in caring someone. And our plan is to have a physical location, first in New York, where we can have physical therapy done, music therapy, and art.
With such a large patient population suffering from Lewy body dementia, it is absolutely vital that medical professionals and families understand the symptoms and treatments for this disease. For more information or to find out how you can help, visit lewybodyresourcecenter.org.
I want to thank our sponsors, because if it wasn't for them, we wouldn't be able to do this today. Thank you to April and Howie first for your generosity and for that of your family always. Thank you. Thank you to Katie Pargament, who donated her bat mitzvah money. And her family is always very generous to us. Thank you to the whole family. And thank you to Marissa Stefatos, who's one of our co-founders, who also donated so that we could do this today. So why was Lewy, thank you, yes. Thank you to all of them. Why was the Lewy Body Dementia Resource Center founded? My mom had the disease for many, many years, and she lived with me for the last 7 years of her life. And one of the people I see is here today is my friend Audrey, who cared for my mom for those 7 years. I'm so grateful. I was leading the support groups in New York, the only support groups in New York, for the past 11 years in Manhattan and 10 years on Long Island. We now have 2 others. But as I was doing that, and I was getting calls, I was the only contact person in all of New York, I saw how much information and resources were needed. And they had no place else to go. So thankfully, I met 4 other women who are now my friends, colleagues, and all 4 of you, would you mind standing up so everyone can see? Come out so people can see. Suzanne Pargament, Susan Visconti, Marissa Stefatos, come on out, and Eileen Stern. And these are my co-founders and friends, and all of whom cared for a family member who had Lewy body dementia. And that's why we know the disease so well, and we want to help as many people as possible. And by the way, we are all volunteers, and so your generous donations are much appreciated. What is the mission of our organization? Our mission is to bring awareness to as many healthcare professionals and the general public as possible There are so many people, as many of you know, who know nothing about this disease, and generally I speak in many places and hardly any hands go up when I ask if someone knows it. So it's really important to us. The second part is to bring support, loving support, as we like to say, to all caregivers who desperately need it. Because besides having so many symptoms with this disease, both physically and mentally, there's an added burden because so many people haven't heard about it. And people just don't understand it. For those of you, I know many of you know the disease well because you're caregivers. But what is Lewy body dementia? I want everyone to know, and I need to say this loud and clear, it is by no means rare. It is the second most common form of progressive dementia after Alzheimer's disease. There are more people who have LBD than are HIV positive. There are more people who have Lewy body dementia than ALS, muscular dystrophy, cerebral palsy combined. It is not rare, but it's very, very often misdiagnosed. And for those of you who may not know, it's the disease that Robin Williams had. And as of 2 weeks ago, Ted Turner just announced that he has it as well. So we are hoping that it will get more awareness so that people know it. And I'll tell you in a minute why it's so important to be diagnosed correctly. For those who don't know the symptoms, in simplest terms, people will say it's a combination of Alzheimer's and Parkinson's. It's not exactly correct, but you have to have an issue with cognition, meaning executive function problems. You're having problems with your daily activities, daily retrieval. In addition to cognitive problems, there's Parkinson's symptoms. For those of you who don't know what those are, because most people that I've talked to think, oh, that's when your hand is shaking, is what they say. Yes, so some people do have a tremor, but many people with Lewy body dementia don't even have a tremor. But other Parkinson's symptoms are rigidity in the arms and legs, or stiffness, a shuffle when they walk. So you've probably seen many people do that. There's also a jutting out of the chin and a blank stare, and the mouth could be open. That's a typical Parkinson's look. So if they have problems with cognition and Parkinson's symptoms, and they also have fluctuations, and that is key. People who have Alzheimer's disease may be the same every day. They could forget things, they repeat things. When someone has LBD, they can talk about what's going on in politics today and may not be able to answer a simple question tomorrow, or even later on in the same day. There are also hallucinations, most commonly visual hallucinations. A curious part of this disease is that people who have hallucinations that are not frightening are of small animals and children. But there are also those who have very frightening hallucinations. And those need to be helped with medication many times. Another early sign is a REM sleep disorder. And what that means is the person is thrashing in their sleep. They can be punching the person next to them, having nightmares, could be talking in their sleep. And that seems to be an earlier sign for many. There's also a visual spatial component, which means that there's a problem with depth perception. Someone may reach for a glass here, but it's really here. They may hit a curb with a car. Why is it so hard to diagnose? It's hard to diagnose because you can't see the fluctuations in a doctor's office. You can't see the visual spatial issues. You may not even notice the dementia in the same way because in a doctor's office, we call it showtime. They're acting perfectly normal. So why is it so important to be diagnosed correctly with this disease? There is no cure for Alzheimer's disease, there's no cure for Parkinson's, and there's no cure for Lewy body at this time. It's because people with Lewy body dementia are extremely sensitive to medications. And medications that are given that are inappropriate for them, such as older antipsychotics in case they were having frightening hallucinations, can put them into what's known as a neuroleptic shock coma. And if they're given wrong Parkinson's medications, if they have Lewy body, they can be given hallucinations with the wrong drugs. And so that's why we have our panelists today, And as I welcome them, I hope they can answer many questions for you. They have most of the information about this disease, and I'm so thankful that you're here. So please welcome Dr. Vicki Schenker. Come on up. Dr. Stella Caranzulis. Dr. Joyce Fogel. And nurse practitioner Yael Zweig, who worked with Dr. Galvin, who was on there.
I first want to thank Norma for inviting us today and really gathering everybody here together, because I think it is something that is just not talked about a lot. As you said, it's sort of known amongst the movement community, but not known amongst the population. And for that reason, people don't seek help early enough, and doctors and general neurologists may not recognize these issues early enough. And so I think it's really important that we all talk about this today. And so it's kind of crazy to think that I have to talk about all of the medical treatment in 10 minutes or less, because it's a really multidisciplinary effort, to be honest. And as a neurologist, we're really focused so much on the motor symptoms and the cognitive symptoms, but we are treating sleep, we are treating depression, we are treating anxiety, we are treating hallucinations, we're treating all of these elements. And so there is no drug that is approved for the treatment of Lewy body dementia. We use the medications that were tested for other things. There were certainly studies in some of these drugs with Lewy body, but they were never approved for the use in Lewy body. There is no book that says this is the first thing that you do, this is the second thing you do, and then follow along. So a lot of it is from the literature that we use, but also a lot of it is just from our own clinical experience. Obviously, as a movement disorder specialist, a lot of times the first thing people come to me for is to see if they have Parkinson's disease. So the symptoms that often come through my door first is the Parkinsonism, and as eloquently described, that includes all of the things described, and I would add to that the slowness in movement, or bradykinesia, which is something that that is actually the number one key feature that we see, in addition to the stiffness, which people may not recognize as stiffness, and the tremor, which we can or cannot see in Lewy body. So of course, the first medication that we often go to is that gold standard medication, carbidopa-levodopa. Why don't we choose a lot of the other medications that are available in Parkinson's if we suspect Lewy body? Sort of as just eloquently described, because of the side effect profile. There are many medications that are used in Parkinson's disease, the dopamine agonists, amantadine. These drugs can really set off hallucinations. And so the preference is for carbidopa-levodopa because it has the least amount of side effect profile in terms of harm to our patients, and is the most likely to help their motor symptoms. That being said, even regular carbidopa-levodopa can set off hallucinations. So if, as a movement disorder specialist, first the approach is always very slow, because you kind of want to take things along step by step and kind of watch and see how your patient is responding to the medication. If you just ramp them right up to, some people look up in the book and go, okay, 1 tablet 3 times a day, you may set somebody off into hallucinations or worsen their cognitive status. So carbidopa-levodopa, and I will add that a lot of my patients with Lewy body who came to me before I even met them, or were treated before I met them with controlled release carbidopa-levodopa. This is more of a Schenkerism, not something that you would see in a book. But the fact is that I've had a lot of patients who said, well, I can't tolerate the carbidopa-levodopa. And in the beginning, when patients came to me with controlled release, I said, oh no, I have a better drug, let me give you the regular drug. And they didn't like it. It didn't sit well on them, and I ended up putting them back to controlled release. And over the years, I have often found that some patients who feel like they can't tolerate it have done now better with controlled release. So sometimes I'll go with it first or switch people over to it if they're having problems as I titrate them up on the carbidopa, levodopa. Another thing for motor that I should tell people about if they don't already. I know a lot of people here are very clued into the motor treatment, but Zonogram. Let's show of hands, anybody hear about Zonogram recently? Oh, wow. Okay, so this is actually pretty exciting because Zonogram is an older drug, not old, probably about 20 years old, and used with seizure treatments. In Parkinson's disease, over 10 years ago, there were some studies in Japan in which they were giving Zonogram in patients with Parkinson's and showed that they had more on time with their carbidopa, levodopa. A study this year came out in Neurology, which is one of our highest journals, that basically tested Zonogram in patients with Lewy body. And what they found is that they had improved motor time, better walking with the Zonogram without worsening of cognition. The doses were just once a day. They started patients on 25 milligrams once a day. They brought people up to 50 milligrams once a day. About 20% of people had side effects that meant that they couldn't tolerate it. But this has been actually something cool and new to use in our battery of medications. I actually do have a patient with Lewy body where we had a very dramatic effect quite recently in which he was really at a point where he needed assistance to use his walker and he wasn't communicating well and came back after the 50 and his sister and his partner were there and he walked the hallway without a walker at all. Wow. So that had a very dramatic Zonogram effect, but certainly something to consider now and just be aware that it is now as an option, I think. To move on off of the motor things because of my limited time, cognition is obviously one of the first things that people feel interferes with their daily life. Probably even more than feeling a bit slow is the cognitive fluctuations. So the acetylcholinesterase inhibitors, donepezil, rivastigmine, those are the two medications that are sort of considered first line. And I will tell you, even from 12 years ago when I was in training, we used to, when patients had hallucinations, we would go right to the atypical antipsychotics, Seroquel, Clozaril. But what has been reported and what we have found over the years that with mild hallucinations, that these drugs actually often kept things at bay. And they have often helped me increase the levodopa too. And in fact, sometimes when cognition isn't a big deal in patients, I try to encourage them to consider going on to one of the two acetylcholinesterases first because I often find it allows them to tolerate the levodopa if I need to increase it upwards. Both of those medications are generic. I like the rivastigmine because it's a patch, but there's no proof that one is better than the other. The rivastigmine comes as oral as well, but it tends to make people a little bit more nauseous than the donepezil. And so those are sort of the first line. Memantine and Namenda are often used as well. It is approved officially for moderate to severe Alzheimer's, but again, they have used memantine, which is a completely different mechanism than the other two drugs. And sometimes I use both those medications in combination with each other. For Alzheimer's, there were studies where they showed that the two in combination were better than one alone. So sometimes when people find that they have sort of maxed out the acetylcholinesterase, I will add that into the mix. For hallucinations, as I mentioned, the first thing that I would do would be try an acetylcholinesterase like donepezil and rivastigmine. But if they're very pronounced, then we do go to the Seroquel or quetiapine as one option. Quetiapine, all of these antipsychotics have black box warnings. Some people like to go to that first because the clozapine or Clozaril, which is more atypical and the least likely of all antipsychotics, that are dopamine blockers out there. It's the least likely to cause Parkinson's symptoms, but it needs to be monitored via the blood because of white blood cells. So in the beginning, people need weekly blood draws, and then they need to go to every other week blood draws, and then after 6 months, they get to go to once a month blood draws. So it's or a year, after a year, you get to go to once a month. So it's a long process, and some people like to try the other medications first. But I will tell you that Clozaril can often decrease tremor in some patients, so for some people, it's an option. Nuplacid's the newer one on the market, was not tested in Lewy body dementia, was tested in Parkinson's dementia. And the only thing to be aware of is that it's under investigation from the FDA because there was more deaths than expected. So we don't know, but it's still available, and there are some patients who are on it. And I'll just end with saying that, okay, so with REM sleep behavior disorder, often because of cognition, the sleep specialist will tell you to try melatonin first, which is really something that was not used until, I would say, the last 5 or 6 years. There's been a real push to try melatonin first. I'm on a panel with the Academy of Neurology, and one of my colleagues is a sleep specialist, and he was telling me that we're a little gun-shy in movement disorders, that he often finds that patients need between 10 and 20 milligrams of melatonin, when I often start people with 3 to 5. Because these drugs are not FDA regulated, he said there's large variability in the melatonin dosing, and just to consider pushing it up higher. The other alternative, of course, is the clonazepam medication, which helps about 80% of people with REM sleep behavior. Do I treat everybody with REM sleep behavior? No. If I find the spouse is in another room, I encourage that. If the person is really physically active and throwing themselves off the bed and I'm worried about injury, I have had patients break jaw, break ribs, and other sort of things. So I do encourage bed safety, but I often really do at those times encourage medication. This is just a drop in the bucket of treatment. I haven't talked about really the multidisciplinary care, a lot of things that Norma has on the website in terms of being physically active, physical therapy. Exercise is probably one of your best preventions for fall, but also for cognitive decline, for physical decline. It's one of the best things that you can do to help prevent that. Getting involved in activities, and there's a lot that's, especially in this city, is really important. So I definitely would want to emphasize that this is just one piece in terms of, and all I've addressed is the motor treatment and a little bit of the sleep and so on. But this is a real multidisciplinary effort, and and I could just go on from constipation to bladder difficulties to blood pressure issues. One of the things that's now more recognized in Lewy body is that there's more autonomic dysfunction. They've actually now highlighted that in the criteria, so you can see more blood pressure drops and so on, which can contribute to falls. And I think it's one of the things, again, that we as physicians, we try to go through the checklist and be aware of, but I really do try to encourage my patients. A lot of times people think, well, this is not for you, this is for somebody else, but actually it is it is part of this disease, and I should know about it too. So I hope that was a little helpful intro, and I look forward to your questions later.
Good morning, everyone. My name is Stella Karantzoulis. Hi, everyone. I am a clinical neuropsychologist, and I'm going to talk a little bit about what I do, because it is different in that when you come to see me, it is not about what medicine I'm going to prescribe, because I don't prescribe medicine. What I do is I look to see how is your brain functioning overall, given what we know what Lewy body disease affects, or other types of illnesses or injuries to the brain. So what I do is try to relate brain systems and structures to how we think and feel, because they're obviously very connected, and it's important to understand what's really going on. What is that person experiencing every day, and how is that affecting their overall functioning? So a neuropsychologist like myself is someone who has a doctorate degree. And we have further specialized training in the field of neuropsychology. We tend to work very closely with neurologists, with geriatricians, with psychiatrists, and we work in a team because each of us will complement the work that we do. When you come to see a neuropsychologist, most often what we're hearing is there's a change in the way that they're thinking. Tell me a little bit more. Well, they seem a little bit forgetful. They're struggling to come up with the words they want to say. They're slowed down. Or maybe it's, all of a sudden, my wife seems a bit depressed. They're withdrawn. She's not talking as much. She doesn't want to do things. So it's not always something cognitive, but there's some sort of change in that person which sparks a concern in the family member. So we know with dementia with Lewy bodies what that sometimes looks like. It's not always the same in every patient. Some of my patients do report feeling really forgetful early on, whereas some of them say, I don't have any problems with my memory, but I just feel off and I can't concentrate. I can't focus on my work. It can be variable from patient to patient. Sometimes people come to see me without even having seen another doctor before. They're just online looking to see, memory doctor, my memory's off, what do I do? Or something is wrong, who do I see? It's unfortunately not such a clear path to get to a neuropsychologist all the time. So what we do though is first and foremost, we do help with the overall diagnostic picture. So sometimes it is helping their doctors or the families confirm a diagnosis. What we also do is really just help that person, the family, understand what is really going on, where are the weaknesses, but also importantly, what are the strengths? Because we know that the whole brain isn't affected. We know that there's pockets of weakness, but with each of those weaknesses, there's strengths. And importantly, I think, is how do we use those strengths to compensate for the weaknesses? So when someone comes to see me, oftentimes people think, oh, neuropsychologist, it takes hours and hours of testing, and it's so awful. I'm going to like to think that it's not so awful. And with me, I try to keep testing at no more than 2 hours because I know it's difficult. But obviously, we want to be able to answer and get a real comprehensive evaluation. But I am going to put the person through a little bit of testing where I'm going to ask them to remember things. I'm going to ask them to put things together because we know visual spatial skills are affected early on. So I might give blocks, I might give a puzzle, I might give a complex figure to copy because I want to get sort of a lot of evidence within each area to see what's really going on. We know memory is not one system, there's many aspects of it. Does the person take information in but they can't hold on to it? Is it there but they just need help getting it out? So it's important that we assess a broad range within each domain, so memory, attention, language. It does take a little bit of time, but the important information that we can get from that 2 hours of testing is really going to go a long way. Then what I'm going to do is I'm going to look to see how each person scores on my tests compared to other people the same age, same gender. We know that men and women differ. We know age plays a role. We know education plays a role. So I'm going to take into account all that information to get a solid understanding of how you are doing compared to your peer group. I'll calculate all the scores, and I will formulate my own diagnostic impressions. I will write a report, and that report will get sent to you, the patient, the family, or to the referring physician. But I think what's most important in that report is a treatment plan, and it is recommendations. We know this person is in the early stages of dementia with Lewy body. We see that their attention is a little off. We see that they're having trouble with visual spatial skills. We see that their problem solving, their higher order thinking, those executive functions are off. Now what? What does that mean? Can they still work? If they're going to go back to work, what kind of modifications or strategies can we do in their office to help them? Do they have to stop working? Do they have to stop driving? How does the family deal with that? Some of my patients have young kids. Then what? What does the kid understand? How do we help the family? So there's a lot of aspects that we got to, work through together to try to help the patient and the family get through this. It's not a one-stop shop. We're going to establish weaknesses and strengths and try to figure moving forward, how do we use those strengths to compensate for the weaknesses? I might suggest a medication based on what I know has helped other people, but my focus is obviously not on the medicines. It's on strategies to improve everyday life to keep that person as happy and safe and their overall quality of life as strong as possible for as long as possible. So that's really what I do. You're welcome.
Very much. I'm sure that was new information for many of us. And now Dr. Joyce Vogel.
So, I'm a geriatrician, and as you look at this panel, this is a multidisciplinary panel. People are coming from different aspects of healthcare. And I'm going to talk to you a little bit about why you might want a geriatrician on your team. First question is going to be, well, what is geriatrics? The word geriatrics actually comes from the Greek old man healer. And geriatrics focuses on both promoting health and dealing with disability and disease in older adults. So a geriatrician is usually either an internist or a family practitioner who has additional training in dealing specifically with the issues of older adults. They are trained to work in a team approach. They learn to deal with frailty, disability, and patient preference and family preference, as well as end-of-life issues. So it's really very different. They also learn to deal with the unique aspects of the older adult. So what are those unique aspects? You know, basically, an older individual is just not someone who's chronologically older and needs the same things, right? So as you get older, there are changes to the body that are normal aging. For example, your kidney function declines with age, and that may affect how medications are prescribed and in what doses, right? We know that hearing loss is normal, can be normal with age, high-frequency hearing loss, which may even affect the way you're dealing with somebody in a group setting, right? We know that older people take more medications, more prescription medications, and more over-the-counter medications. So it affects their health care because dosing has to be different. Older people also may have what we call syndromes, geriatric syndromes. They're not one diagnosis, like someone who's recurrently falling. It may be due to many things. They may have many medical problems, not just their high blood pressure, but their high blood pressure, their diabetes, their osteoporosis, and on top of that, their dementia. So they have many things. And diseases present differently. So if I got pneumonia, the chances are that I would have a cough and a fever, and I would go and seek medical care. An older person, especially one with cognitive problems, might just be more confused or more lethargic and may never show the fever or the cough that is a presenting symptom of pneumonia in a younger person. So some of these things sound like your family members or the person you're caring for with Lewy body? Yep. So who needs to see a geriatrician? So basically, people who need to see a geriatrician or who might benefit are those who are dealing with multiple medical problems, frailty, cognitive issues, functional issues, multiple psychosocial problems, because they're going to help coordinate your team as well. So your team could be all in one place. You're fortunate enough to be working in a center where all these disciplines work together. That's great. But it can be a virtual team. It can be your geriatrician speaking to your neurologist, talking to your physical therapist, interfacing with a social worker, or your caregiver. So it can be an on-site team, it can be a virtual team. So the team approach is really important in geriatric medicine, right? So the next thing people ask me is, I need one of these. How do I find one? Where do I get one of these people? Right? So you can, the American Geriatric Society has a consumer website called Health and Aging. You can go to healthandaging.org, and there's a list of healthcare providers who deal with geriatric issues, so by state. So you can do that. You can, if your neurologist, if your other healthcare providers are associated with a particular hospital or university medical center, call them. Ask them if they have a department or division of geriatrics. Because it's always better to try to have all your team members in the same place, because they can email each other, they can interface, and hopefully they can read the same medical record. Not always true. So that's one way. Ask. Go to places like these resources. Ask Norma. Look for places where you can find a geriatrician. But regardless of whether you have a geriatrician or you have a trusted internist who you've been seeing and then they're on your team, I just want to give you some tips for when you're either starting out with a new physician or when you're going to that medical appointment. So the first thing is, know what training your provider has, because that's going to help you know, are they the right person? When you make that appointment, is that office handicapped accessible if that's important to you? You know, you're caring for someone who has a walker and you get there and there are 10 steps up and no elevator. And you've spent all this time getting there and then you say, we can't do that. So is the office handicapped accessible? How do you communicate with the provider? Does their medical record have an electronic portal for you to communicate through, which makes it really easy? You're having a tough time at 3 in the morning and you need to get something out. You're not going to call them, but you can send a message via the portal that they're going to see the next day, right? What do I do if I have an emergency? How do I call? How do I communicate? Does this healthcare provider interface with the hospital if someone gets hospitalized? So those are all things you sort of want to know ahead of time when you're going to a medical appointment. Prepare for those appointments. Make a list, because when you get there, even though that list is in your head, chances are you've forgotten it. I tell people, keep a notebook that you take to all your medical appointments. So you go to the neurologist and you've written down some things, and now you have to go to the cardiologist, and the cardiologist says, what did the neurologist say? Because they're not on the same medical records. And you're nervous and you forgot. So put it all in one place, or make a healthcare binder where you have sections for each thing. It'll keep you very organized, The section for the insurance card, the section for the medication list, the section for the list of all the physicians, a section for reports. Prioritize when you're going. No, these are the 5 questions I want to get answered. So you get them answered up front. I can't tell you how many times people come into my office. I have my agenda. I want to make sure to find out this and how did this happen, and I sent you for this test, and I want to go over this. And they have some questions. And now I am out the door, and they say, I forgot to tell you, Mom fell last week. So now I'm walking back in the room, and I don't have the same time that I would have had if I heard the first thing, Mom fell last week, and look, her knee is bruised. So make that list and prioritize. Because the reality is you're going to have a limited amount of time. You're not going to have 2 hours. So you want to get the most you can. Always keep an updated medication list wherever you go. Don't assume that the next doctor you're seeing, you have that list, or you're now sent to the emergency room. Don't you have that list? Not necessarily so. If you're really worried about getting bad news or being able to process everything, bring a buddy with you. Say to a friend, can you come with me? Because this is going to be a really difficult appointment and I need somebody else to hear this, or a second family member. So regardless of where you're getting that primary medical care from, make sure that they understand that you need a team approach and that they're willing to communicate with you and coordinate your care. So thank you.
Thank you, Dr. Fogel. And now we have Yael Zweig from a different perspective.
Everyone. So I met Norma probably about 8 years or so ago through my work at the NYU Memory Center. And more recently, I've transitioned into a role where I do inpatient geriatric consultation. So in the unfortunate event that your loved one would be in a hospital, the role of the geriatric consultation is similar to what Dr. Fogel mentioned, which is to really clarify the unique needs of an older person in the hospital. And as you know, patients with Lewy body dementia in particular, the burdens of hospitalization are really high. And so Norma asked me to talk a little bit about the impact of Lewy body dementia on caregivers. And my biggest concern and fear is that this is a perfect scenario in which I'm preaching to the choir. So I just wanted to see, show of hands, kind of who in the room is a caregiver. Okay, so quite a bit. So I think through my work with Dr. Galvin and through my work in Lewy body dementia, what I've come to understand is really the unique experience of caregivers. And one person with Lewy body dementia is one person with Lewy body dementia. And every case is really unique. And that's where talking about the caregiver experience can be tricky because the way it affects each person is different. What I wanted to do is kind of look through some of the evidence about the caregiver experience just to be kind of up to date and talking about what we know. And a lot of it comes from a Lewy Body Dementia Association survey about 10 years ago that went to, I think, about 1,000 caregivers just to understand what people were really experiencing. And that allowed the Lewy Body Dementia Association to understand where to focus their resources. And what we knew back then is many caregivers were women, many caregivers were spouses. And a lot of the experience really spoke to what Norma described initially, which is really the diagnostic challenges and the delay in diagnosis, sometimes up to 2 years. And the fact that most families had to see more than one doctor over multiple visits to come to a diagnosis. And as Norma mentioned, the reason for that is really multifactorial. It's the fact that the person in the office looks like they're having a great day that day, and the caregiver might not have connected the 20-year history of, occasionally punching out in their sleep or acting out their dreams, which, they might have not connected that to the longstanding constipation and to the kind of subtle change in walking and the thinking trouble that's kind of there but looks really different than it would be in someone with a disease like Alzheimer's disease, which is kind of more recognized. And then once a diagnosis is made, families often spoke to the trust in that diagnosing provider, but the fact that once the diagnosis was there, where they felt there was a lot of gaps is, what do I do from here? What are the community resources? What other referrals are available? And that's because in a big city like New York, there's specialists, but obviously in smaller towns and smaller cities, that might not be the case. And primary doctors might not be as skilled in understanding these diseases and the repercussions it has on the whole body and the autonomic symptoms and the like. And so I think some of this hopefully is changing in terms of public perception. One of the challenges in caregivers is you tell family and friends, oh, this is Lewy body dementia, and people say, like, what is that? And you have to understand it and describe it. And hopefully with Robin Williams and Ted Turner and more kind of awareness and Norma's work, some of that might change and reduce some of the isolation that goes along with it. But the kind of to the present, the more recent survey spoke about, was an end-of-life survey to talk about patient and family experiences. And one of the things that was described is this kind of lack of discussion by providers about what to expect for the future. Only 22% of providers spoke to families about what to expect in a helpful way. So just to kind of mimic some of what Dr. Fogel said, what I wanted to do is talk a little bit about how to plan for the future. And one of the things that I think is really important as caregivers is for every person to have a healthcare proxy. And a healthcare proxy is when the individual with Lewy body dementia appoints someone who would make their medical decisions for them in the event that they lose capacity to do so in the future. So it only applies when the person's unable to direct their medical care. And even if you say, well, I'm the spouse and I'm always with them, you never know what could happen for the future. And I think it's really important to start to have discussions, as difficult as this is to talk about, to start to have discussions now, especially in the early stage of disease, when the person can really be clear about what their wishes are. This is called advanced care planning, and this is something that geriatricians can help with. And even though geriatricians are amazing, I think some of what you'll experience, particularly in New York City, is that there are significant waiting lists, right? Would you agree that it can be challenging to find a geriatrician, and sometimes there's the ability to do geriatric consultation where you would keep your primary care provider, but you would be able to see a geriatrician on a consult basis to help with some of these discussions and to review medications. And in geriatrics, we de-prescribe, which means that we reduce medications instead of add medications, which is even more important often than adding another medication. And so advanced care planning includes the healthcare proxy as and really the discussion about what's important to someone and quality of life. And a living will can sometimes go along with the healthcare proxy, which talks about what someone would want in the future. And it can be helpful, but the language in there can be kind of limiting if someone gets the language usually has to do with what they would want with a severe brain injury or a terminal state, and that sometimes doesn't really tell a caregiver what they would want in more Lewy body specific circumstances, which would be how important is it for them to be home? What about swallowing issues that can sometimes develop? And so I always advocate for finding the right time and the right place to really sit down with a loved one and talk about what's important to them. If someone does have strong feelings about what they would want, there is also something called a MOLST form, which stands for Medical Orders for Life-Sustaining Treatment. And this is a form that are actually medical orders and allow the person's wishes to be followed in the moment, so in the present, and then continuing into the future, and always renewed by a physician. But I think especially if someone is transitioning through multiple settings, hospitalizations, back home, rehab centers, then these documents can certainly ease these discussions and avoid having to rehash someone's wishes multiple times with multiple providers. So I think just as a whole, the other thing I'll say is that in reviewing the evidence, I think what's helpful to think about in geriatrics and in caring for Lewy body is always the benefits and burdens of everything. So when Dr. Schenker was talking about symptoms, we're always thinking about when you treat one symptom, then the other symptom can get worse. And so similarly in caregiving, there can be burdens, but there can also be benefits as well. And one of the things that we see in diseases like Alzheimer's disease is this loss of insight, where the person feels like everything's totally fine and they have absolutely no concerns. And in Lewy body, sometimes that insight is retained, which can in some ways help the caregiving relationship, because there's a level of sort of generosity towards the caregiver and understanding their circumstance. And the reason why I bring that up is because there was this article in just a few months ago that was more of a descriptive article that really talked about this provider in Sweden's experience caring for a patient with Lewy body and his wife over 15 years, and really talked about kind of the course that they went through and how the changes in medication and the decisions affected the patient and what the patient's experience was, and really spoke about how the patient managed the symptoms of the disease, including something as really just practical as making sure to take a lot of naps, and this patient was actually able to continue in a reduced schedule in his work, and he would say that he kind of understood that he needed to nap for 2 hours before he participated in something related to his work. So I think there are kind of unique opportunities to treat and manage symptoms that are very patient and caregiver specific. And I think the Q&A section of this is probably most interesting, everyone. So I think we can get there. Yeah.
Thank you very much, Al. Thank you to all of you. Let me see how many questions there are.
Hi, thank you so much. This has been so helpful. I think the one question that I have is that, first, is there a natural history study of Lewy body dementia patients over time? Because one of the big questions I have is that I hear that it's not like Alzheimer's and it's not like Parkinson's, it's in between, but what is it? Like, what am I going to see from the progression of the disease in my mother? And one of the big questions is like, is she going to forget who we are at the end of the day? And what do these patients die of at the end of the day, and what do we have to kind of watch out for?
It's a tough question, and patients hate when they know, actually they'll ask me, so, what's next, how many years? And they're like, you're not gonna answer that, or are you going to? And I'll tell you one thing, and this is why it's complicated, so I'll try to give you a short and a long, and the complicated thing here is that this is a heterogeneous condition, okay? That when they go and do brain pathologies on these patients, and actually, I have a wife of one of my patients here, what did we find? He had Lewy bodies, but he also had Alzheimer's pathology. And in fact, that's been coming out more and more as well, that actually if you have any Alzheimer's pathology or even carry an Alzheimer's gene, it may make the Lewy body worse. And so this is not something that we'll see. So we go, oh, well, Lewy body doesn't have Alzheimer's symptoms, but there are going to be a small percentage of patients where we're going to see some of both. And so when why somebody can't tell you is because you'll say, well, I have a patient who they went 25 years and they did okay. And then I have a patient, why did the next patient rapidly deteriorate in a couple years? There's such variability, and I think some of it is really kind of understanding the disease process better. I always start with an optimistic attitude, and I tell people, very often my experience is people can be very stable for 10 plus years. It's not, and the normal experience is not that they forget their family and their loved ones. But can I guarantee that cannot happen? No, because it's more complex than we understand. Lewy body is becoming, just like Parkinson's, we don't like to call it a disease anymore. Why? Because we know that there's a variety of things that cause Parkinson's disease, right? Some of it is genetic, some of it is exposure, some of it's a combination of both, and that's why, as was put, when you meet one person with Lewy body, you've met one person with Lewy body. Okay, so I work in an area in which we have a lot of genetic diseases. Well, guess what? We now see that people who are Gaucher carriers are more likely to manifest and look like Lewy body. Okay, so does the Gaucher carrier who has Lewy body clinically the same as the next person with Lewy body? No. And that is what, that's what we're trying to understand. That's what we're trying to study. So that is why you'll never pin down a clinician. However, your questions of what to expect is what I would tell you is that these key or core features, variably present in different orders. So there's not like this happens first and then next month this is going to happen and then next month this is going to happen. And in fact, when we go through a list of things, not everything in that list of things will happen. But you would expect that I would tell you of all of the things that the cognitive issues are the most complicated. In some ways, as a movement disorder specialist, I feel blessed because the Parkinson's, as we talked about, with some of the medicines can be very limiting because of the cognitive aspect. And I have many patients with Lewy body who can be physically independent for a fairly long period of time without requiring the kind of medications that Parkinson's patients need, 4 or 5. Parkinson's patients can be on 4 or 5 medications easy for their Parkinson's. And many of my patients with Lewy body can get away with just carbidopa, levodopa, or another drug and kind of be okay. The cognitive thing is, is variable. And so very often my experience has been is that they're very stable and that there's some point where there is a deterioration unpredictable. And like that is why preparation and kind of, preparing, because there is not like that date. I have never been able to predict that when that will be because there is such great variability. But I think that being physically active and cognitively active are things that will help people, maintain, and that's kind of an approach.
Because there's so much heterogeneity in the disease and so much is unknown, it's very hard to run clinical trials here to help with the disease. I think a natural history study is really critically important so that people can design clinical trials and people can run different clinical trials to actually study this in this specific indication. And whether it's through this organization or through one of your institutions, like, this is the perfect audience, and it's so important, I think, to advance research
I would
in this
add, yeah,
area.
there is. And I would also add to that this is why, and this is very difficult to talk about in general, but why more people need to donate their brains after they pass away. Because if you look, that even movement disorder specialists are wrong a decent percentage of the time. That we think that someone had Parkinson's and they find Lewy body pathology. We think someone had Lewy body, but they have Lewy body and Alzheimer's pathology. And in fact, I've had 3 people recently who had both. So I think that you're right, following people through, but those are the people that we identify clinically that we're like, oh, you meet all my features, so I know what you have. But the truth is that there's many people who actually have Lewy body pathology and we're missing because we're only going from these clinical features that we plan. So I feel like, again, I'm a cheerleader, very difficult to have some of these conversations that the geriatrics can have and so on. But it is something to think about because I think that the more we understand about what's happening with the brain, the more we can then go back, like you said, and have a better clinical understanding. In terms of clinical trials, I will add that the Gaucher's has been very promising. And so, again, you should know that there's active clinical interventional trial. We actually our site at Beth Israel, and for Gaucher's and in patients who have Lewy body, and there's more coming down the road. So for those patients who have a Lewy body presentation, who are Gaucher's carriers, some of these patients will be qualified for some of these interventions. So there is things that are happening from very specific pathologies that we understand. That's why certainly if you're Ashkenazic Jewish, you might consider finding out if you're a carrier and meeting a geneticist and kind of doing that study. So again, I 100% agree with you. It's being done, but I also think it has to be done the other way so that we can kind of hone down the disease.
And I'd like to mention that we do have someone here who brought brochures on your way out. There is a new clinical trial being done, and it'll be at Columbia Presbyterian. We have information on that you can get on the way out.
I just want to add one thing. You asked about how do people die. And there are a lot of ways, but infection is a primary way. So I want to make my plug. Please get flu shots, both you, the person you're caring for, as well as the caregiver, because you're the person who's going to bring them that flu in. So herd immunity. And they need to get their pneumonia vaccines. So don't say, Mom doesn't leave the house, she doesn't need a flu shot. Error. Please, please get them their pneumonia vaccines and their flu shots.
Thank you.
So the new shingle shot is a whole other thing. That doesn't matter, but yes, talk to your caregivers about it. It's much safer than the old one because it's not live virus. It requires 2 vaccines, 2 to 6 months apart, and most pharmacies are out of it right now.
Any other questions right now?
How you doing? Thank you for all your information and all that. My question is about CBD oil and using it with patients. We're trying to use it with her mother, but they say I read that the clonazepam and the carbidopa, it interferes with it. So I was wondering.
Oh man, you guys are throwing them at the. So CBD oil, I mean, the truth is that just the data isn't there right now. So, do I have historical reports from patients of benefits? Yes. Is there support in even the Parkinson's literature for using CBD oil? There just isn't the research. All we have is either negative trials or a third it helps, a third it's worse, a third it does nothing. I even just wrote a book chapter for pain and Parkinson's and went through all of the CBD oil data in Parkinson's, and it's just not good data. So does that mean it doesn't help? No. I mean, certainly I think that I've had patients specifically where it's helped in sleep and in pain, and certainly in a time in which people used to get prescribed opioids, I cannot tell you how I'd much prefer them to try the CBD oil than the opioids. So it is approved for these issues. In Lewy body, there's even less data. It's just clinical, like, your N of ones. And so for sure, if someone's not eating, if they're not sleeping well, I might consider it. In terms of the clonazepam and levodopa, I have had patients with REM sleep behavior who have needed to be on clonazepam and added CBD oil. I haven't seen someone have a negative reaction, but the biggest side effect is going to be sleepiness. So you have to monitor for those things. I've also had patients with Lewy body dementia who have taken CBD oil and hate it. Like the family member said, let's try it, and they were sleepy all the time. So at this point, it's anecdotal, and I believe that as it becomes more legalized and there's larger trials, we'll have better data for it. But for motor symptoms, there's not great data.
Thank you. Sherry.
Yes, I want to ask what Dr. Galvin is doing in Florida now. He's doing research, right?
Yes, I can get an update and send it to Norma to share it, because I don't want to speak with it. You can tell me.
I can tell you, because we're part of the same group, and I'm continuing to collaborate with Dr. Galvin. He is now seeing patients as well. So about 20% of his time is patient-related care, primarily research, and he's a principal investigator on a number of the drug trials within dementia with Lewy bodies and Alzheimer's and movement disorders in general.
Okay, thank you.
Yeah.
And small doses of Klonopin cause visual hallucinations to go from good hallucinations to bad hallucinations.
Good question. Typically, I haven't had patients have worsening hallucinations on the clonazepam, but I do think that people with dementia, they're more susceptible to weird things, and certainly it would be possible. It's not a classic side effect from the clonazepam, but any drug that we give has the possibility of going to scary. And certainly, if somebody told me that, I wouldn't just say to them, well, that's not what clonazepam does. I would try to lower or take off the clonazepam and see if an alternative made the hallucinations any better or milder. Yeah.
Thank you. Any others? We'll take two quick ones. Yes, Nathan. Yes.
Hi again. I would say thank you again for the information. It just comes at the best time, but it's never the best time in terms of taking care of loved ones. But my question is, if you go to one doctor or two doctors, you get 10 different answers. This panel here has brought to light new medications, treatments, unfortunately successes and not successes. But how do we share this with our geriatrician? Sometimes we feel the research we do, for instance, with my mother took Nuplazid from a neurologist outside of her practice. The geriatrician practice had never heard of that or had never prescribed that. So what at a higher level, as you are the experts, if you will, educating and getting the medical body itself educated on, it is variable, so I guess there's no magic prescription here, and this is step 1, step 2, step 3. But in terms of sharing the information among yourselves, who can then guide us for the expected and unexpected.
I think that's why you need a team approach. There are a lot of things I don't know about. I'm not a neurologist, but I'm willing to help coordinate care. So if a patient comes to me and says, my neurologist told me this, and it's something I don't know about, I'm reaching out to that neurologist. I'm going to find the time, whether it's why you keep things in one institution, or I can email them and say, could you explain this to me? I'm not quite sure I know this. I can look it up myself. There are going to be a lot of things I'm not aware of, but it's all about being open-minded to learn and be part of the team. And I think that's the important thing.
Yeah, I agree. I think that listen, I have a lot of patients, they don't even live in New York. Some live in the South, some live in Florida, some live out of the country. And the most important thing is just to have an open-minded clinician who's nearby them, who's willing to work with you. It's not reasonable that that I can see, they can even come to see me sometimes as frequently as they would like. And I think you just need someone who, I know that I have my own limitations and I reach out to specialists when I don't understand. And so the only times that patient, and I'm living this with a patient right now with progressive supranuclear palsy, where they have a doctor in Florida who's just like, well, it cannot be this. It's not this. So they're feeling ping-ponged between two clinicians. I do think that in New York City, one of the things, as sort of mentioned, is you can go to 10 doctors and get 10 different responses. So I always just encourage people, once you find, for example, a specialist that you like, pick one. Because everyone has their own style, and it's not that it's right or wrong, it's just their style. And so if you like someone, if you go, I've had patients like they see their NYU movement specialist one month and the Columbia movement specialist, and they come to you, and you don't want to keep making that crazy mix. That there is no right or wrong. There's just certain people's style. Find someone you feel comfortable with, and then make sure that you must have someone outside of the movement disorder world, and that there are someone who's open to collaboration.
I would just reiterate, go with your gut. I think people don't listen to their gut enough. And you're with a doctor in that room and something doesn't feel right. They're not paying enough attention. You're not getting you're not heard, and you feel that, go with that. I think too many people ignoring just think, I was told they're the #1 specialist to see. That doesn't matter. Listen to yourself, and like you're saying, pick the person that feels right for you.
I was just wondering if there's progress in brain study of not autopsies, but in live brains. Is there more going on in terms of being able to study people who have and who don't have the disease before autopsy stage?
Yeah, I cannot attest to all the research going on, but certainly there is a lot of functional neuroimaging studies going on. Some of them happen at Columbia. North Shore does a lot of research in that. And so you see kind of how the brain is actively working and how it's metabolizing and changing. I always tell patients that the clinicaltrials.gov is really a great way to see if there's something that's going on that you might be able to be involved in. Especially because in New York, there's often places somewhere in traveling region that you can see if that's a possibility or something that you might be interested in. A lot of the studies actually are of these things, and patients actually say to me, well, I want the treatment. Like, what's the study where I could maybe get a treatment? But there's a lot more of studying the evolution through neurocognitive testing, through neuroimaging, and so on. So again, if you go to the clinicaltrials.gov that's run by the NIH, you can actually put in the keyword Lewy Body Dementia, and you can pick actively recruiting and just pick New York State or Florida or wherever, and you can look at them and see if there's anything that might be right for you. I try to do that before I see patients, but often they'll come to me and say, do you think that I might be a candidate for this? So there are things that are going on.
What about post-mortem brain donation? If a patient has requested that his brain be donated, I've heard that you need to actually plan that ahead of time. So how do you go ahead and plan that?
Yeah, so now when my patient was going through it, we were going through a process of organizing it at Mount Sinai. At Mount Sinai, there is actually they have pamphlets out. There's now an organized way to set it up. So you just tell your doctor. All you have to do is tell your physician. NYU has a brain bank as well. And so if you tell your clinician that it's something that you might be interested in, then they can connect you with the information for it.
And you can do it yourself you can Google any of the major medical schools. We'll do it because I've had patients bring me the forms that they've done themselves.
And I will just tell you that it's right on our website.
There you go.
I will show that. I'll show that a little bit later, just really briefly. But it is right under resources, is brain donations, and we have information on 3 or 4 different places. So at this point, I thank you all so much for being such a wonderful panel. One of the main reasons for providing resources for families is because they have nowhere else to turn. Nobody else understands the disease. It took me a year to navigate where to find the right doctor. Where do I get home health aides? How do I get a hospital bed? And people have asked me these questions, and I never wanted them to go through what I went through. So I created a website with 4 other of my friends and colleagues who are former caregivers because we knew every aspect of the disease. In addition to our website, we offer a live helpline and support groups, as well as individualized care. And that's what we are trying to provide, most importantly, to the people and families who are suffering with this disease. Not everyone who has Lewy body is the same. They are all individuals, and they needed to be treated accordingly. Every person reacts differently to medications. Every person reacts differently to certain situations. And because we have all been through it and taken care of people who have had the disease, we know the little nuances that people need help with that others don't know.
One of the most important things that we want to do is to alleviate the burden of caregivers. Our helpline is so important, and our support groups are so important because people get to talk to each other, give each other hints about how to handle certain situations. And what I find is that speaking on the helpline and giving these people the comfort of knowing that we know what they're going through. I have gotten many letters and phone calls saying, "You're an angel from heaven. I don't know what I would do without you." One person moved to Georgia. It was a terrible trip with her husband, and she called to thank Norma and I, saying that she could never have gotten through it without our help and services, and that's why we continue to do this.
For more information or to find out how you can help, visit lewybodyresourcecenter.org.
Pamela Rosenblum, I'm so sorry, who's currently, she's a retired psychotherapist, currently caring for her husband. And Paula Sierra, who has been caring for her mother, who has Lewy body for many, many years, in fact, since she was 19.
I'm very pleased to be here talking about being a caregiver. The first time I was asked to talk on this subject, I said no. And I had been a caregiver for my husband, and he passed away in July of 2015. And a few months after that, I got a call from one of my colleagues who is now a hospice nurse, hospice and palliative care. And it was just a few months after he had died. And she said, "Judy, we're giving a symposium on dementia. Would you like to give a talk?" So I said, "Sure." And she said, "We'd like you to talk about caregiving." I said, "What?" I said, "Are you kidding?" I said, "That's the last thing on earth I want to talk about. I don't even want to hear about it, and I don't even want to think about it." We've all heard about caregiver stress. You know, I don't want to scare you about that if you haven't done it yet, because it's a sort of a thing. I think life is stressful, and of course caregiving is stressful. And when there was a show of hands, I don't think the majority raised their hands when they asked who is a caregiver. But even if you're not a caregiver now, you may have been one in the past, and I'm talking about adults now, or you may be in the future. So this is very, very relevant. And as a geriatrician, I had a particular kind of experience. And when I went to give that talk, it was actually a multidisciplinary audience. And even these glasses that I'm wearing today tell a story, because it was the first time in a couple of years that I had given a professional talk. And during the time that I was a caregiver, I wasn't exactly taking good care of myself. And so for the first time, I had to put these blankety-blank glasses on, and I was fumbling around with them. So I really didn't know what to do. I was a newbie. I was sort of back in the real world. And so, you know, I had refused to give this talk, and I had gone, I hung up the phone, and I sat down, and for about 5 days in a row, I started writing down all the things that I could talk about. And I made a list of about of several dozen things that were very, very important. All the things that I had learned as a caregiver, all the things I had done, and the common theme, all the things that I had written down were, well, gee whiz, I knew what to do, but what if I had come into this job as a caregiver, not as a geriatrician, with all the patients that I had seen who had had dementia, and working with all the caregivers that I had worked with. I had to give this medication, I had to give this injection, I had to take him to this doctor, he needed a specialist for this. I didn't know what to do. Usually I did, but when I didn't, I could do things like call Joyce Fogel and ask her, what do I do now? Let's have lunch, help me. I knew how to navigate the healthcare system. There's so many things that I came into this job with that all I could think about was, what do you do if you don't have this kind of background? So I actually gave lectures to physicians a little bit. I had to sort of medicalize it slightly so that it would be more interesting, because the theme I really wanted to convey was the most important thing that a physician or a nurse practitioner or any clinician can do for their patients, for the caregivers, is to facilitate communication. So, I can say that, you've got to communicate, you've got to do this, you've got to do that, you should make house calls and all those cool things that would really be valuable for the caregiver. But what your speakers before helped you with, and Dr. Fogel in particular, because we think alike, right, Joyce? Because we're geriatricians, she gave you the recipe. Because you, if you are trained, if you know how to get your questions answered, then you're way ahead of the game. And one of the things that I like to tell patients and caregivers is, when you go to the doctor for the first time, do not leave that office without getting a phone number to call if you have a question. And I don't mean 911. I mean, if you have a question, there's got to be a nurse or there has to be a doctor on call who can answer that question. That's how you start. So you got a lot of good, useful information from Dr. Fogel and from some of the other speakers as to how you can school yourselves. Now, my husband and I actually were both geriatricians, and we came into this world, I guess, sort of prepared in a way. When we bought our apartment, we said, you know what, we better get a flat. It's got to be all on one floor. We're on the second floor. We need an elevator building. I mean, I had done house calls in fourth floor walk-ups. That was not easy. I didn't mind walking up the stairs, but the patient couldn't walk up and down the stairs. We had healthcare proxies. We had long-term care insurance. These are all things that I can tell you as caregivers or future caregivers who are cognitively intact to do. You can get yourself a healthcare proxy, that's great. But of course, if the person that you're taking care of does not have the capacity to make a decision now, it's too late for that. But one of the things that I want to do in the few minutes that I have is to reassure you about a lot of things, because I could say I feel your pain. I guess I should say I'm feeling my pain. From some of the questions I heard, I could feel my pain. And I know how difficult these things are. So it turns out that I go back a long ways when it comes to the advanced care planning field, and had a lot of anguish over some of the decisions that had to be made for patients at the end of life, for my patients. But fortunately, well, in 1990, the healthcare proxy law was passed, belatedly, happily, and it's a great statute. We don't have a living will statute, but that's okay because you can have a generic living will and so on. But the good news is that in, I think it was 2010, the state, after 17 years of debate, passed the Family Health Care Decisions Act, so that even, I'm not telling you not to get a healthcare proxy, but even if you don't have a written advance directive with your wishes on it or who you want to appoint, the government, fortunately in the state of New York, has provided gives a hierarchy of surrogate decision makers who can speak for you. So 2 things I want to say before they drag me off the stage. And the first thing that I learned as a caregiver, well, one of the last things I learned as a caregiver was that when my husband was in desperate need, not from the dementia, but from one of the many comorbidities that elderly patients get, that's why a geriatrician is a good thing to have, he developed severe shortness of breath. And I knew where the morphine was in the refrigerator because it came in a box that I was disregarding. I wasn't expecting him to have this problem. And I was shaking so hard from something that I had done so many times, which was prescribe morphine. I couldn't open the blankety blank bottle. And so I had to call the hospice nurse, and she helped me. She calmed me down. I opened the bottle. Not only that, but she instructed me carefully on drawing it up with a dropper. It was liquid morphine, and what line on the dropper to draw it up to. So I was able to give the morphine to my husband calmly, and it worked. We needed to let him sleep through this respiratory distress. So the lesson that I learned, and I want to share with you, is you must rehearse. If there's a gizmo that you have to handle, or a drug that you have to deliver, or anything that you have to do for your loved one, you better rehearse. Don't leave the office. Don't let the nurse out of your home until you're sure that you know how to do it. You may have to rehearse it more than once. Rehearse. And the other thing that I want to share with you is something that I learned a long time ago as a physician. One of my patients who was very, very sick, she was a double amputee, she was blind, and she had heart failure. And we were sitting together, and I was taking care of her. She was very with it. She did not have dementia, but she had everything else. And there was a woman across the room who had dementia. And my patient said to her, "Boy, she's lucky. She doesn't know what she's going through." So that was a very important thing to hear from one of my patients. And one of the ways that I was able to reassure caregivers when I was working with dying patients, one of my patients' daughters said, "I can't watch my mother suffer." So I wasn't going to say something crude like, "Well, don't watch." I had to very sensitively tell her that, I said, "We're the ones who are suffering. She's not feeling any pain." And by letting her know that, she was very relieved. And that's very important. So I'll give you one anecdote from my experience as a caregiver, and then I will sit down. About 2 months before my husband died, and I didn't know it was going to be 2 months, his very beloved sister, who was living in England, was very, very sick, and she died. And I had to give him the news. Did I have to? He was with it enough that I needed to share it with him in some way. So I made sure he was diabetic. I made sure he had eaten, and I'd given him his insulin, and his blood sugar was okay, so that if he went into a terrible depression, that at least his blood sugar wouldn't go down too much. So I told him. They were very, very close. I think he loved her more than he did me, but that was okay. She was the most beloved person in his life. She was his older sister. So I told him, and he looked horrified. And then I left the room and I checked out. I had caregivers. I didn't want to talk to anybody else the rest of the day because I was suffering. 2 weeks later, we're sitting there and he said, "We haven't heard from Joan for a while," his sister. I didn't say a word, but I'm only bringing this up because dementia, we talk about how terrible and this and that, but there are certain situations where it protects your loved one. And it's important for you to know that because that will protect you. And it protected me. And I was really glad that he had forgotten that his sister had died. And I'll leave it at that.
Thank you so much, Judy. Dr. Aaron. Pamela.
Right into it?
Please.
Okay.
Yes. And from
No,
this
I'm
is
not gonna say
again
that.
from a personal caregiving perspective.
Hello. I'm going to sit. So I'm shifting gears somewhat, and I'm going to start with an analogy. It's a scientific fact that when a caterpillar encloses itself in a chrysalis, the metamorphosis into a butterfly involves the complete dissolution of the caterpillar before it is reconstituted into a butterfly. And I believe it's an existential fact that experiencing the person you have promised to love and cherish till death do you part fall slowly into the world of Lewy body dementia will cause an existential metamorphosis in you, the caregiver. It's a dramatic analogy. But last week I woke in the middle of the night with the word alchemy going through my mind. It's the idea of transformation that struck me. As a psychoanalyst and caregiver, I decided I wanted to speak today from my own personal experience and address the profound emotional impact on the caregiver. And perhaps sharing that perspective, I hope some of these thoughts might be helpful to the caregivers and maybe even to the medical professionals here. Nothing could have prepared me for how the diagnosis of my husband's Lewy body dementia would affect me. We had already been through 2 hospitalizations for genetically induced deep vein thrombosis and pulmonary embolisms 5 years apart, 3 months of grueling radiation and chemotherapy for stage 2 throat cancer, prostate surgery, and a knee replacement. I thought I was an expert caregiver. The first lesson I learned, which serves me well now, happened before Paul, my husband, was even diagnosed with Lewy body dementia or Parkinson's, which came first. His walking had been slowing down considerably, and I had noticed a kind of glassy stare as he walked. But the orthopedist saw only his arthritic knee. The urologist was concerned with his peeing, and the cancer doctors were just thrilled as he passed his 4-year mark. It was when I said to our primary care physician that something is terribly wrong with my husband that I learned my first lesson. As his wife, I have an overall picture of him that the specialists can't have. And so began our journey, first to a diagnosis of Parkinson's, and 2 months later to a primary diagnosis of Lewy body dementia with Parkinsonism. And I should mention, we jumped to that diagnosis because he got an infection, he got bronchitis, and that caused a blossoming of all his Lewy body dementia symptoms. And that's how we turned the corner into that primary diagnosis. So I learned from the very beginning that I needed to observe and articulate a holistic view of my husband to the medical professionals. Paul and I are still actually in the fairly early days of this journey. He still knows who I am most of the time, except when he thinks the other Pamela is with him. Paul began to be confused at times about who I am and who our son is this past June. I learned this as he started saying things to me like, "You went down to see your friend Anne, but the other Pamela came back." At first, this totally freaked me out. It felt like being in the Twilight Zone. I really expected Rod Serling to be standing in the corner. And our 27-year-old son said to me after his father said, "So Sam, you're my son, huh? Where did you grow up?" Our son said, "It's like being in a psychological horror movie." And yet, now, when he gets confused, we just talk about it. I find it amazing that his brain can cause him to think that the other woman helped him shower in the morning, and also allow him to talk about it rationally with me later in the day when he says, "This is the strangest thing I've ever experienced." Once I mentioned to him that we're lucky that he's able to accept the fact and talk about it with me. That some people, when they experience this confusion, get really lost in this "you're not my wife" feeling. And he said very sweetly, maybe they don't have a wife who can explain it to them. I don't know if that's true, but I learned at that moment that we both feel better if we can find some way to acknowledge that we're in this together. And that's the alchemy I'm talking about. with each new stage of the strange developments in the progression of this disease, I have felt literally emotionally torn apart, but then somehow reconstituted to be able to be present to what is. For me, one of the most difficult parts of this disease is the unpredictability, and you've heard mention of that earlier. Symptoms ranging from GI issues to feeling dizzy and woozy, to changes in his visual perceptions, to his cognitive ability changing, to name a few. These can change dramatically over a 24-hour period. And this can make the caregiver hypervigilant and on edge. But over time, I've taken the advice that was given to me to be water. Be like water. Go with the flow. I've found that this experience has challenged me to confront myself, to feel untapped depths of loss and despair and anger, and then to reach inside and find a way to be present to the person I love. When I attend support groups, Norma's is one of them, I attend 2 different support groups, I realize that I'm with others who are similarly challenged. And to tell the truth, I think we rarely talk about the darkest times, even in our support groups. The middle of the night panics, the middle of the day overwhelms, and the times we've lost our patience and snapped in anger. But we all know those depths are there. So what is your weak spot? Is it abandonment issues? Is it needing to be in control or perfectionism? This experience will make you stretch and humble you. And I've actually found myself using the serenity prayer from this 12-step tradition. The serenity to accept the things I cannot change. That's a huge one that I've gone to over and over again. To accept that attending a movie with me is too overstimulating to his nervous system, that I must walk with him at slower than a snail's pace despite my propensity to walk like a true New Yorker, that his inability to see something that's right in front of him is frustrating to him as well as to me, that I will see on my husband's face the face he turns to a stranger when he doesn't know who I am. I could go on with all the day-to-day little acceptances that add up to a huge acceptance of the things I cannot change. And then the courage to change the things I can has really been important to me this 2nd year since his diagnosis. This involves finding new ways to take care of myself. I've had a meditation and Qigong practice for many years, and I've been attending Norma's wonderful caregivers group. But it's an ongoing challenge to parse the difference between the things I cannot change and the things I can. Mostly, changing the things I can involves something about changing myself and what I'm doing. I've begun to socialize more with friends, and I now attend an additional support group at the Zen Center for Contemplative Care. And I've made theater arrangements, and I'm planning on some respite care so I can go out of town. All the while missing my partner and carrying a broken heart. One last piece of advice I hear often is to find ways that my husband and I can still enjoy life together. And when I'm railing against what is, that feels like very trite advice. But last weekend we went for a drive in the country, and we both thoroughly enjoyed ourselves. And sometimes we can still enjoy just hanging out and watching silly TV together. And I read the headlines to him in the morning, and we go out to lunch in the neighborhood. And believe it or not, he can still beat me at Scrabble. At least he did last week. Thank you.
Thank you so much, Pamela, for sharing that with us.
He beat me last week.
Now, Paula, you
Yeah.
ready to?
Yeah.
Thank you.
So I guess I'm going to come from a perspective of being at a young age and it being an early onset case. And I think the common thread here is the delayed diagnosis. So my mother was born in 1953. She came to New York from Columbia in the 1970s. In 1986, she became for the first time a mother to my older sister, and in 1988, I came. As I fast forward her beautiful life, we arrived to 2007
when she was misdiagnosed with Alzheimer's disease. The misdiagnosis plays a major role in our journey and leads to what I would like to speak of today. Upon reflecting, as a 19-year-old, I was still grappling with identity and purpose in life. And with this new situation we had to face, I can say with certainty that we were not given the tools nor the resources to either improve her lifestyle or mine, especially because we were going through a reactive stage of denial or disbelief. Firstly, my mother's misdiagnosis led to the prescription of medicine that was only worsening her. She went a couple of days without any sleep and constant tremors. We took her to the emergency room where she was detoxified of the medicine. About 2 years later, I recall a neurologist she was referred to mentioned this disease to me, Lewy Body Dementia. However, it was done so without any further explanation or any further instructions. So we left that appointment with newly prescribed medicine. The gaps that were missed here were tremendous. Despite it all, I decided to seek support on my own. I called Sunnyside Community Services, and they started picking up my mom in the daytime to attend their facility and to do activities with others like her. As my mother's condition worsened rapidly, we realized she was becoming more dependent and needed a home health aide. From then on, my mother has remained mostly in the house. The progression of her condition was taking a toll on my mental health. A family friend had directed us to the Alzheimer's Association. I reached out to them for counseling, which they provided, and I stayed connected with them for about 6 months. Then that day came, when I truly thought that it was the end. My mother suffered from her first of many aspiration pneumonia. At the hospital, a neurologist came and insisted that I stop using the term Alzheimer's, rather Lewy Body Dementia. I was older then, which meant I was able to do more research and actually listen to this disease. I searched for and called resources, which led me to wonderful people, one of them being Norma Loaf, and the other my therapist, Lillian Medina. While my life was deconstructing itself, the Lewy Body Dementia Resource Center showed me how to reconstruct it all over again, despite the obscurity of it all. Through them, I was able to put my mother in hospice care after a recovery stay in a nursing home, and the hospice care team taught us so much more, and it was always done with so much care and out of love. Because of them, we now have appropriate equipment in the house, from a Hoyer lift to an oxygen tank to, very importantly, a suction machine. And boy, have back braces become our best friend. We also found the power in playing soothing spa music while we execute our daily duties with Mom. As an update, my mother, in her last stage, is currently wheelchair or bedbound, and we have a doctor on call for her. I am hoping that in 2018 and in the future, we continue to see more knowledge and more resources than before, and that we all become more conscientious of the particular needs of those with Lewy Body Dementia and of their caregivers and their families. So, every day may easily seem like a waiting sentence, but that thought is quickly suppressed by the responsive and alert look in my mother's eyes when I call for her, or when she produces the only sound she is capable of making with her voice, ah, when I call for her. That continues to fill me with joy, strength, and hope. Thank you.
Thank you so much, and I know how difficult it is to share those stories, and I'm very appreciative for doing that. So I want to open it up for questions, but there may be questions from caregivers who may want to ask these who have been dealing with it so far. And I'm here to answer, and so are my colleagues. But please, if anyone has any questions, please know if you can.
Directed to this young lady. Your mom needs to come here. How did you avoid not having to put her in a nursing home?
That's a good question.
I was just going to say, they gave me the phone. Your mom has so many problems. years ago, they would immediately put people in nursing homes. How did
Right.
you get the services so you can care for her at home?
Yeah, like I said, that's a really good question because that's something that came up a lot, and they would tell us to consider a nursing home. But I guess a lot of factors played into why we kept her in the home. One of them being, I guess, maybe our culture. We are Hispanic, and I guess, our background, we take care of our family. We take care of mom, grandma, grandpa, father. It's all like a family. The family is the team. And secondly, she did have a stay in the nursing home because she was recovering from her first aspiration pneumonia. So we were told that because she was still in antibiotics, that she needed to finish that in a nursing home. So we listened and we kept her there. We were there with her day and night. We would shift. I would go to work. I would go in the nighttime. My dad would be there in the daytime while I was working. However, the care wasn't the same, and it's not to say that if you choose nursing home, that's not a good idea. Everybody has their own experience, but in my personal experience, the care wasn't the same. Not to get really personal, but they weren't changing her adequately or at appropriate times, for her toiletry needs, and therefore she produced a burn, a rash on her skin. So those things played a factor on why we decided, I think for our sanity and I guess, I don't know, just to be sure that she's safe, we rather have her at home.
Thank you. Any other questions? Anne, yes.
Okay, well, this is a comment and then a question. I was a caregiver, and early on somebody said to me, don't get mad at him, get mad at the disease. And that was a big, big thing for me to hear because it was so easy to get angry. But it wasn't his fault. I just wanted to say there were 3 things that I did for myself and still do. I started sending my laundry out. I hired a housekeeper, and I bought a Keurig so I could have a quick cup of coffee. But I just wanted to ask this question, and this may be for the next panel. If you could talk about the difference between long-term care insurance, catastrophic major medical insurance, and what to do in planning if you want to get rid of your assets into a blind trust so that you don't have to wipe yourself out financially to go into a nursing home, although that was not my choice and I didn't do it and wouldn't have.
And we won't be talking about that today. We don't have an attorney on the panel, intentionally actually. But we have information on the website, and I think in the next few minutes after this Q&A, as we get ready for the next panelists, I'll just briefly show you the website so you can see quickly. Because I know a lot of people say, I don't want to look on the website, I'll call the helpline. You're more than welcome to call the helpline every day if it is helpful to you. But if I show you the website quickly, I think you'll see that there's a lot of information in there, and we have a lot of elder care attorneys on there who people have recommended.
Just quickly, my mom's actually in a memory care house. Godsend. Do it early.
Where are they?
Rochester, New York.
That's not around the corner from us. But I'm happy that you're saying that.
Because honestly, and when I've referred to mom's disease as Lewy body disease, because as soon as you hear dementia, everybody shuts off. Oh, I know what that is. I'm like, no, you don't. So add that in, and people, well, what is that? Well, what does that mean? And then they have a whole different tune into what's going on.
There is absolutely a stigma, absolutely
So
for sure, yes.
Do yourself a favor, and of course talk about it as dementia, but make sure you refer to it as a disease, because it is.
It's a brain disease.
Yes.
Yes, and some people hear that better than hearing that it's dementia, yes.
And then, like I say, and then as I've talked about it, I'm amazed at how many people in my life around me, my daughter's friends, their parents, their grandparents, that have been diagnosed and had no clue that anybody else in our community had it. So it's worth the talk.
We've had some contacts from Rochester, and I was asked to speak there. I haven't gone there yet, so maybe we can
Please
speak
let me know.
afterwards.
I'll stop by and give
Definitely
you my
will.
card. Please do.
Thank
'cause
you.
her neurologist has been asking if we want to start something up there.
Great.
So, thanks.
Thank you. Norma, could I just jump in on that idea that I live in a very big social building where people raise their families and then their families, and so everybody knows each other. And so I've noticed, though, that when people ask about my husband, I often just say he has Parkinson's, because I've noticed if I say he has anything with the word dementia, people won't say hello to him anymore. It's ridiculous, because he can totally talk to them about lots of things. So it's sad. I think it's where we were with the word cancer 60 years ago.
I totally agree. Unfortunately,
Yeah.
we are still there.
You know, when I was caring for my mom, I couldn't even hear about hospice. That brought in a different connotation to me.
Mhm.
So I know then
Mhm.
I did, and it was a godsend for me because it made much better networking for me and took a lot out of my hands. So could you talk about that just a little bit more?
Yes, totally. So it was actually Norma who had mentioned on the phone to me to consider that. And yes, it does have a negative connotation. You immediately think, oh, death, or they're going to die. Or when I would tell my close family and friends, they were like astonished. Why are you going to put her through this? Is this the end? And so I had to explain, I learned the information and the appropriate knowledge, right? I had to explain that it's not necessarily the case that they're going to pass away. It's just that they need a different type of care that a home health aide or a regular doctor cannot provide. And we quickly learned that because the team was just so ideal for my mother's needs. And they also explained to me, the nurse that would come from the hospice care, she would also tell me, it doesn't mean that your mother is going to die or pass away. It's just she has particular needs that only we can provide, for instance. So I hope that answers your question.
I just want to clarify something, though I'm happy it appears that way. Generally, the criteria for being on hospice is that they are expecting that the person will pass within 6 months. That's the criteria. It could happen. So what they do is they will put someone on hospice. It's usually if you've had a hospital stay or an infection, if you've lost weight. They have certain criteria, and they will come to your home anytime. They'll spend 2 hours with you taking much information that I know Dr. Ahrenheim can speak of. But I just want to say it could be that they are on hospice for 2 or 3 months and then they reevaluate. It does not mean that they might necessarily pass away in 6 months, but that's the criteria. I can tell you from my personal experience, which is not the norm, since my mom had this disease 18 years, which is far from the norm, she was on hospice 7 times.
Right. Yeah.
So, Dr. Ahrenheim is actually an expert in this field. She is.
I just want to define a couple of terms, hospice and palliative care. They're not exactly the same. Palliative care is a general term which an easy way to explain it is it's comfort care. The goal is not necessarily to cure the disease, but it's to make you comfortable, to provide as good as possible a good quality of life physically as well as psychologically. So that's the general term of the type of care that hospice provides. In the United States, hospice refers to an administrative entity. So it has to do with Medicare and other insurance reimbursement, and certain criteria have to exist. So roughly speaking, the person has to have a 6-month prognosis. I say roughly speaking because that can be bent a certain way. So if you become a patient in hospice, there's a different kind of reimbursement through Medicare and some of the insurance things, but really the issue in both hospice care and palliative care is to address the person's symptoms. The idea is not length of life, but quality of life. So if the person has, let's say, 6 months to live, and usually we admit patients to hospice later than we should, because the average duration of life on hospice is about 30 days. So they could be on hospice and reimbursed for much longer than that. So it's an approach to care. We don't look at, maybe he's got appendicitis and we better take it out. We look at what is this thing that's causing a problem, what should we treat, how should we treat it, and how can we make this person comfortable? So there are two different concepts, but hospice has some regulations in terms of how long it will pay for and will you qualify. So if you don't really qualify for hospice, that doesn't mean you can't get the same kind of comfort care.
Right.
Any doctor or any nurse can keep you comfortable.
Right.
And you want to get
Especially
somebody.
a geriatrician.
Well, not only a geriatrician, but we should all be learning how to keep patients comfortable.
Thank you.
My husband was enrolled in hospice. I was afraid. I said, "Oh, that's premature. It's not time yet." But fortunately, somebody was counseling me, who's supposed to be an expert in this. Suddenly, I'm a caregiver. I'm not an expert anymore, and got me to agree that yes, it was okay. Then we had to make sure that he qualified for hospice because in dementia, whether it's Lewy body or Alzheimer's or whatever, the prognosis is not usually as clear cut as it is with someone who has end-stage cancer.
Right.
It's not as clear cut.
My father has Lewy body dementia, and he suffers from being agitated all the time. And I was wondering how you deal with that at home. It's been a big problem getting him care and I guess, getting his medications right. And I was wondering, that's like my biggest concern is how to manage getting his, he gets so angry, he's violent. And I had aides come and they turn away and, he's now in the hospital and we're just trying to get his medicine right. Is that like an ongoing thing or, I guess my question is how do you cope with that?
Actually, that would have been a better question for not that.
I can say
that,
something about it.
You want to
Yeah.
answer that quickly? If you don't
Yeah,
mind?
okay. So agitation and violent behavior and lashing out.
Yeah.
Well, in any form of dementia, including Lewy body dementia, things progress. And sometimes the period when there's a lot of acting out and maybe even violent behavior can sort of taper off as things progress. It's bad news and good news because the disease progresses, but that kind of behavior tends to wane over time. But there's another issue, and that sometimes certain kinds of confrontation may just be something that create a great deal of fear for the person, for the patient. And the way that you approach the person can sometimes help. So there's certain modifications you can make in terms of interaction. So if there is one family member that maybe knows how to speak to the person a little bit better, or if there's another one who may be confrontational, says, "Why are you acting like that?" So there are different ways that you can approach the person, and not everything has to be medicated. We can modify our behavior to the person that can help as well. And then there are also somebody who suddenly becomes very agitated. There may be an underlying medical problem that needs to be addressed. And for example, if somebody is very severely constipated, that's just one very sort of silly example. But so the person needs to be looked at very carefully to see what could be modified. So it's not all inside that this is a violent person. There may be other factors involved that can be modified, such as your approach to the person.
Thank you.
It's complicated. Let me see the patient.
If you look on the top where it says resources and professionals, when you click on that, you will see it says New York and Florida because we don't only have resources for all of New York, for most of New York. We only have a little bit in Rochester, but not for a lot of other places. We also have resources for Florida. And we will be adding resources for the state of California and for Michigan. Takes a long time. We're all volunteers. We're looking for volunteers while they're getting ready. I may as well say that now. If anyone, we need people to do research for us because we want to provide information on people who know Lewy body in every state. And at the moment, it's New York and Florida. If you click on resources and professionals and then click on New York, you will see a large list of doctors, of dentists, of occupational therapists, physical therapists, brain donations. It's a very long list. Don't let it intimidate you. Click on it, and there's a lot of information for you there. Secondly, under caregiving and support, there's information on helping with bathing, with feeding. We have resources for Meals on Wheels, for veterans information, for surgical supply stores, just about everything you can think of, because we put information on this website for anyone caring for anyone with any disease, not just Lewy body, because when people were looking for information, instead of going from place to place to place, it's now in one spot. And what we'll be talking about next in just a moment is alternative therapies and resources for you. So when all of you are ready, I will, okay, they're not ready yet. I also want to let you know, when you do leave, as a reminder that we have on the registration desk, there's information on this clinical trial, and it's from the New England Institute for Clinical Research, and we have a representative, Ben Hawthorne, here with brochures for anyone who wants them. You can take a brochure from him and ask him questions. And we also have additional, as I mentioned before, medical alert cards, additional pamphlets. We also have a brochure from the National Institute of Health for any of you who have never seen that and this disease may be new to. It's an excellent brochure. It's about 45 pages on the disease. It explains it better than anything else I've ever seen. You're all ready? I am, but we are. Okay, so everybody's ready, and yes, so we are showing a video that's just a minute and a half before we start. I just want to let everyone know before that goes on that it's a father and son in the video. We all love it. The father, you can't tell in this, but the father has Alzheimer's.
Tell me, when will you be mine? Tell me quando we can share a love divine. Oh, don't let me wait again. When will you say yes to me? Tell me quando you mean happiness for me. Oh, my darling, tell me when. Every moment today. Finish it. Every day seems a lifetime. Let me show you the way to a joy beyond compare. I can't wait a moment more. Got it. Tell me quando. Say it's me that you adore. And then, darling, tell me when.
The video that you just saw reminded me very much of my connection with my mother in terms of singing together, dancing together, enjoying music. Now, really, music connects to the part of the brain that has to do with memory and emotion. Now, holistic and alternative therapies are really the best way to really maintain a wonderful quality of life for your loved one, to boost their confidence, to stimulate their neural pathways, and it's a wonderful way to maintain a connection and to really do activities with them, to really find what it is within them that inspires them, that they love, if they're an artist in some way, or if they have some way of expressing themselves. Now, a multitude of activities help out in terms of maintaining the quality of life. In terms of the activities that you choose, the best way is to look to the patient, to look to your loved one, to look at their strengths, as Ms. Caregiving said before. I have seen results of these activities. Also, as a drama therapist, I've seen a result of working with people in drama therapy. My mother was someone who loved music and dance. She's the one who inspired me in terms of what I do. In terms of the times when we would get together and sing and dance, it was a time that I'll never, ever forget. And it was basically every day, which was structured.
And this repetition really helped very much. I can't stress enough how important it is to have a consistency in terms of the activities that you have with your loved one. Because this really helps mold a type of structure. Also, in terms of when you connect with your loved one and connect in terms of music, you can also have other activities that you introduce. For instance, with Lewy body dementia, we often see a shuffled gait, a dragging of the legs. So what you can introduce with music and with dance is the lifting of the knees, which is also an aspect of physical therapy. And a multitude of activities really helps those who have Lewy body dementia. Music, I want to emphasize, is a particularly important therapy because it brings back memories, accessing the part of the brain that connects to emotion. It brought back many of my mother's memories, which help her make other connections to her past, to me, her family, and her friends. It has a profound connection to what is personal. Listening to an old favorite song, just like we saw the father and son in this video, it can take you back years to the moment that you first heard it. We would sing together with my mother, and it brought her back to when she was 16 years old. And I saw a little girl within the eyes of my mother. Many studies have found wonderful explanations for this link between music and memory by mapping brain activity. Songs linked to emotions and memories are like a soundtrack. They correspond with greater activity in the upper part of the medial prefrontal cortex, which sits right behind the forehead. The prefrontal cortex is also responsible for supporting and retrieving long-term memories. And the quote is, "It acts as a hub that links together music, emotions, and memories." Listening to a piece of music, as I said before, serves as a soundtrack. Picture a mental movie that starts playing in your head. For instance, even you, if you think of a movie, sometimes or a song, if you think of a movie, perhaps, and you hear a song, it may bring back an image to you. So, have a soundtrack for your loved one. Put together a soundtrack for them and go through it with them every day. And this could be your morning ritual or your evening one if you prefer. One last thing I wanted to say is my last memory of my mother when we were singing and dancing, the last night of her life, was such a wonderful time. And I wasn't really to know that she wouldn't wake up the next morning, but I'm so happy that that was the last memory of her in which we experienced so much joy and which she maintained language and she maintained this connection to love, to me, to her family, and also to herself in terms of what she loved. Thank you.
Thank you so much, Marissa. Now Susan Visconti will talk about.
Buddy, thank you for being here. This is an emotional day for me, talking about all this, listening to everyone. Today would have been my mother's 94th birthday, so I am so proud to be a part of this group. And we've talked about the importance of the physical care, the emotional care, medical aspects. And we did touch upon what I'm going to talk about a little earlier. One of the first panelists mentioned about a living will and healthcare proxies. So my focus is on the legal and financial. We really struggled mightily. Our family was really devastated by not knowing enough about the legal and financial aspects. Okay, so it's really never too soon to start that process. I'm going to just, you'll know what these things are from some of the earlier explanations, and we have more information on the website. You need a will. You need a power of attorney. You need a healthcare proxy. And you need a living will. They each have different functions. You need to have your loved one talk about their wishes as far as what kind of care they want to have. And it's a very difficult discussion. There's a lot of resistance, and there's many different ways to do it in a gentle way. So I want to emphasize that because it is not easy to talk about this. But it's never too soon to start because they take time to get these things in place. You can use an attorney. You can use elder care attorneys. It's really a matter of finding people that you feel comfortable with, going by recommendations from friends and family who have used these attorneys before. The other thing is, I know somebody had asked about the financial part, to protect yourself when you are looking into Medicaid coverage. That is a very daunting task. That is something that I really recommend you go to a professional for. There are Medicaid application companies, but you need to vet them because sometimes they promise you everything and deliver very little. So we are gaining more resources on the website under legal and financial, and we will be having more, so you could look there to get recommendations in the New York area. And the other aspect of this is to, once you get things in place, two things to remember. If your loved one has any life insurance or life insurance policies or stocks and bonds or anything that came from a business when they worked, usually there's a beneficiary attached to these documents, and you have to make sure that that beneficiary is known and put on the document. If you just say in your will, oh, I leave AT&T stock to so-and-so and I leave Verizon stock to the other person, that's not going to hold up. Your assets are not going to be protected or delivered to the ones that you love. It has to be specified on the beneficiary document from the company that owns the stock, the 401k, whatever it may be. The other thing I want to stress is that once you have your documents all set up, and it's going to take 6 months to a year to do that, you need to review these documents twice a year because the laws change, the regulations change from state to state. So it is not, if you have somebody who lives part-time in Florida and part-time in New York, you're going to have to really get that squared away with a certified attorney so that you can be sure that everything is in place should you need it. And that's very important to revisit these things every so often. And that's really what I wanted to tell you. Please start that process. Thank you.
Thank you, Susan. Yes.
Is this on?
Is
Can
that
you
on?
hear me?
Good. Suzanne Pargament, thank you.
In addition to being one of the founders of the Lewy Body Dementia Resource Center, I'm also a social worker in a nursing home on Long Island in the dementia unit. You can't hear me? Oh, okay. Did you hear that?
There you go.
Many family members feel that they need to keep their loved ones home at all costs. But it may become necessary for you to place your loved one in a nursing home when it's no longer safe for you to care for them at home, or the demands of your life don't make it possible for you to be a 24-hour caregiver or to have 24-hour caregiving in your home. It's definitely one of the most difficult decisions a family can face. And in my experience, I have found that many of these dementia patients do well in a nursing home, in the structured environment and the socialization that the nursing home offers. Oftentimes, one of the dementia patients can be home and they would only have one person caring for them that may not be paying that much attention to them, and they would really do better in a nursing home environment. Seeing the residents, staff, and the other family members really help the dementia patient to have stimulation, and there's full-time recreation staff. Many family members have told me that their loved ones are calmer and exhibit less behaviors in that type of environment. But there are several factors to consider when you're looking for a nursing home. The most important factor, in my opinion, is location. The location of the nursing home should be near your home, where you can visit the person often. being an advocate and being visible is probably the most important thing that you could do. The squeaky wheel really does get the grease in that environment. And you should state how you feel about everything. In addition, you should make sure that the nursing home has a dedicated dementia unit. That's not just a locked unit. That's a unit where they have a better staffing ratio, where the staff has been trained in dementia care. It's also important to tour several facilities before you make a decision. Notice how you're greeted by the staff. Check out how the residents look in appearance and facial expression. Speak to other family members to gauge what their experiences have been. But the most important thing when selecting a nursing home is to trust your gut instinct. There will be some homes that you know just are not the right fit. This can be due to the cleanliness of the facility, to the respectfulness of the staff. Your impression and your gut feeling really matter.
Thank you, Suzanne.
I don't know, how does this
You
work?
have your thing. Yeah.
Okay.
Okay, and now we have Jackie Saltzman. Thank you, Jackie. Talking about, Jackie is a geriatric care manager. She'll talk
Hi.
about-
Nothing like being second to last.
What about last?
But seriously, I'm looking at my notes and I said to myself, I'm here, 3 hours? And I'm thinking, they've said everything already. What's left to say? Which brings me to a pivotal point about geriatric care management is we're professionals who have experience in a field related to aging and disabilities, often social work, nursing, sometimes psychology. But we rely on the individuals, the family members who we contract with to bring us the information that's most important about their, I'm accustomed to saying elderly family member. And hard to believe sometimes when I listen to some of the medical experts who were also caregivers, and then the caregivers are medical experts here. We have quite a hybrid community. Caregivers really are the experts, and when you work with a geriatric care manager, it essentially means that you're inviting potentially a total stranger into your home. I personally consider that a privilege because I know that I wouldn't want a total stranger in my home necessarily on a regular basis. So it's in exchange for potentially giving up a significant amount of control, you're also allowing this person to be part of your team. What's particularly important, I feel, about is you may not realize you have a team until a total stranger enters your home and says, you know, apologetically, would you mind if we take a little history, for example? And then you're being called upon to look back and think about what you already take for granted because you've been working on this continuum with or without advice. And so I say this apologetically because I feel that it may seem like a waste of time for you to reiterate my mom has a such and such educational background. We came here from another country how many years ago? The litany of, let's say, family members who are or are not involved. But in addition to allowing a care manager to gather the information that could be the foundation for your future relationship, it's also therapeutic, I feel, for the family to say, oh, someone's endorsing all my experience, and it can be empowering. That being said, the main purpose of an initial visit really is to establish a foundation and develop a rapport. And my focus is always on safety and quality of life. And when I'm thinking about a population like Lewy body dementia that is certainly an underdiagnosed area, quality of life, I think, is something that, except for someone who's significantly experienced with it or in the throes of it, isn't necessarily on the top burner, if you will, the front burner. Most of you seem to know what it's like to be in the moment, and it doesn't feel empowering. So having a plan and someone who is able to put together a plan for you so that if you have an emergency, you know how to deal with it. You have all the paperwork that's necessary to go to an emergency room. None of us want to do that, and that's the first thing that I say. But having said that, when we put together a new profile, what we do is gather all the important information that you would need if you needed to go to an emergency department, any emergency department, even one that's unfamiliar to you. So that would mean having a list of all the demographic information that's important, current medications. I take responsibility for keeping that updated for my own clients. Healthcare directives. Have a copy of it. Don't assume that you're going somewhere that's familiar where it'll already be filed, because if you went to the trouble of having directives, they need to be shared. Another issue is listening to people's priorities, and I think it's Paula, correct? It really hit home to me when she started talking about her cultural background, because, and I'm, by the way, an ex-nursing home social worker, so if you're a born and bred New Yorker and almost never left the country, it's enlightening to meet people who are here, first generation, for example. So as a care manager, we learn to respect whatever the individual's cultural norms are. That will dictate solutions that are proposed. And maybe first solutions and second solutions. Sometimes families need to compromise, and we all understand that. But essentially, my role is to be available to a family at any time, and that means 3 o'clock in the morning, by the way. We don't know what to do. The aide didn't show up. Oh my God, the aide, I thought she was familiar with Lewy body, but now she has us doing XYZ, for example. So one of the things that I think is very important is when you have the luxury of doing that, working with someone who can train an aide and have them understand this is not volitional behavior, for example. We need to respect someone who is not in command of all of their faculties, for example. Maybe we can offer a diversion. Okay, so if you have alternative therapies in place, or even more traditional therapies in place, and we can put together a schedule that makes sense to the household routine, barring circumstances that we can't predict, then we have a full day. So those are some of the areas that impact on having a geriatric care manager. And if anyone has any questions, I have a little handout that I prepared because I wasn't sure what the norm was going to be today. So feel free to ask me for a copy of it.
Thank you very much, Jackie.
Thanks.
Last but far from least, Eileen Stern.
Hi. I just want to touch on a couple of our services, our helpline. Our helpline is your lifeline for caring for your loved one. We have the only live Lewy Body Dementia helpline in the entire country. It's a pretty big thing. Having walked in your shoes ourselves, each of us have learned how to manage the behavioral fluctuations and individual situations that occur with this disease. We're here to help you, support you with love from our own experiences. We'll guide you through the many resources on our website. We'll help you find doctors, neurologists, occupational therapists, physical therapists, daycare programs, veteran services, and much, much more. We aim to make life easier for you and your loved ones as you travel through this journey. Our helpline is available from 8 a.m. to 8 p.m., 7 days a week. Please don't hesitate to call, even if you just need to talk. We are here for you. Our phone number is 516-218-2026, and it's on our brochure, which you have on your, with your packet. Our support groups. We offer monthly support groups in Manhattan, Westchester, Nassau County, and Suffolk County on Long Island. Specific to Lewy body dementia, they're attended by caregivers, spouses, loved ones who need support, guidance, and comfort with the difficult situations that arise with this disease. There's so much to be learned from others who are going through just what you are. Questions are asked, helpful hints are shared, fears and frustrations are discussed.
I'm told by so many from the group that they wouldn't miss these meetings for anything. It's a safe haven. These meetings are a safe haven for you to truly express your feelings, all without judgment. Please give us your email address on the sign-in sheet on your table, or there's a sign-in sheet on the desk, and you'll receive monthly reminders of each support group every month. We're here to help you. Please don't hesitate to call us or come to our support groups. That's all.
Thank you, Eileen. Thank you.
Do you know of any musicians who volunteer to go to Lewy body patients in their homes and play?
Yes.
And how do I find that out?
Well, you can contact me. I'll
How
get in
do
touch
I
with you.
contact you?
She'll give you one of her cards, or I'll give you one of mine, and we'll
Yes.
connect. Yes.
Okay,
Connect
great.
us. Yeah.
Thank you.
Nathan, yes.
This is just operational, practical experience. Luckily, we were able to get community Medicaid for our parents, and we had all the paperwork, and I totally agree, you have to get that in advance. But what happened was we had to go to Chase Bank. I'm not disparaging them in any way. And we had a power of attorney, and they go, oh, we have to have that reviewed. And, oh, how do you review it? Well, with legal documents, they're stapled, and they're not supposed to remove the staple.
Right.
So they go,
Exactly.
oh, you have to take the staple off. And luckily, we had a relationship with the banker, and he was able to somehow copy it and fax it. But from experience, have whatever legal documents you have. Same thing with Social Security. We need to do something for my father. They said, go to the website, and the website asks you, what mortgage did you have? What car did you use? Well, the answers there were wrong on their database. And so we couldn't get through. I had to go to Social Security office, had a power of attorney, goes, oh no, Social Security has their own power of attorney.
Yes.
So unfortunately, the advice would be whatever legal documents that you have, and you have to have any sort of service on it, before it's an issue, go there and talk to them about how to get the proper clearance so that going forward you can go to any Chase branch or any Social Security office and get things done in an expedited manner. I've heard the same thing that investment like Scudder and all these other investment firms, they may have their own form.
Oh, Pamela has an answer.
I was just speaking where my husband has a 401k, Vanguard. I mean, they're all the same. And they said to me, oh, no. I said, I have a power of attorney. I want to submit that to you. And he said, no. We have our own power of attorney form for you. And I said, my elder care lawyer told me that you are legally required to accept our power of attorney. And you are not allowed, you can't do what you just did. And he said, oh, okay. It's true. And he said, okay, so in addition to your power of attorney, ma'am, please send that with a letter from his doctor that's only 30 days old stating his condition. So have a little chutzpah. You got
I want to thank all of my speakers for being here. I'm very grateful for all of them. Again, I want to thank our sponsors, April and Howie First. Thank you so much.
Thank you.
For Katie Pargament, thank you. For Marissa Stefatos, thank you so much. I want to mention that we have an event. This is totally separate. For anyone who's on Long Island or feels like traveling to Long Island, it will be in Huntington on November 4th. We are showing, it's in remembrance of Robin Williams. We're showing one of his comic films, The Birdcage, for any of you who know it, or if you haven't seen it, it's definitely one to see. We're showing The Birdcage, and then there's a new biography about Robin Williams by Dave Itzoff, who is a New York Times reporter. I will be interviewing him. I'll be talking about Lewy body for about 10 minutes before the film. We'll show the film. I'll be interviewing the author of the book, and then we'll have hors d'oeuvres and wine, and he'll be doing a book signing. All for $20. In Huntington, it's Sunday, November 4th. Yes, in Huntington, November 4th at the Cinema Arts Center, and we have flyers on the table right there. So I wanted to tell you that too. And again, I want to say if anybody wants to volunteer, we can use volunteers, we can use expertise, we can use anyone who you think can help us if you want to connect us. We need committee members, and we certainly can always use donations because that's the only way we get funding. Also, if you know of any speaking opportunities, we want to bring awareness to as many places and people as possible. Right in the New York area, but we're willing to travel because to us it's crucial. There's someone here today who's just spoke before who is having a very hard time and getting conflicting reports, and that's right in New York where we have the best doctors. And just, I want to say 4 weeks ago, someone was giving, as you know, I have to say it again, I don't have a medical background when I speak, I just know the disease extremely well from beginning to the very end, but I have expert neurologists on our board. I've talked to hundreds and hundreds of people. One drug is not to be given, as any of the doctors will say, is Haldol. And just 3 weeks ago, I was told of someone about 1 week ago, they were going to give her father Haldol. It's critically important that we get the message out to emergency room staff, to all healthcare professionals of the negative effects that these drugs can have on people. They have no idea because they've never even heard of the disease. And I can tell you from speaking in different places, I've spoken to doctors and new medical students. They all have, if I ask them who has heard of Lewy body, in that group they'll all raise their hand. And then I'll ask them, what do you know? And they don't know anything. They've heard of it because they might have been a paragraph or a page in the medical textbook, but generally they don't know anything about it. And so it's really crucial. So if you know of places to speak, please do let me know that. Lastly, in closing, I want to thank you all again for coming to be with us today. One of the reasons and the main reason that we all founded this organization, and as you see from our tagline, is bringing awareness and supporting with love. That was most important to us, and I can tell you that when we were thinking of that, people said, oh, you mean supporting with care? Or why don't you say helping with support? No, we wanted the word love in there for a reason, because that's how we feel and that's how we want to help. And so in line with that, and in closing, here's a 1-minute film that I think says it all.
Do you know you're my mama?
Uh-huh.
You do?
Uh-huh.
A while ago you said you didn't know you were my mama.
Well, you act like my mama.
I act like your mama?
Mm-hmm.
No, I'm saying you're my mama.
I'm your mama?
Yeah.
All right, I'll be your mama.
Now, do you think that I would lay here with just anybody?
No. I think you want to have to love them if they want to.
Yeah, you do have to love them to lay down with them like this.
Yeah.
And I love you, Mama.
I love you.
But do you know who I am, though?
Uh-huh.
Who?
Kelly.
Yes, Mama. Yes, I am Kelly.
Uh-huh. Well, I love Kelly. And didn't I name you Kelly?
Yes, you did.
Well, I love you, Kelly.
I love you, Mama. I thought a while ago you didn't know who I was.
I know it well. It was something because when I have some fears, I get here and I'm thinking, my Lord, what in the world am I thinking about?
You are?
Yeah.
What are you thinking about right now?
Well, I'm loving you.
I'm loving you too, Mama.
Oh, well, we're both doing the same thing, aren't
yeah, we are.
Oh, isn't it wonderful?
Yes, it is.